We have been asked today to speak to an audience about antibiotic stewardship here at our select hospital, LTAC Hospital in Nashville. I'm David Jarvis. I do pulmonary and critical care medicine and have been the medical director here in the Nashville LTAC for 15, 16 years.
And I'm Julie Horton. I'm an infectious disease physician that practices at Select Specialty Hospital, and I'm the infectious disease program director at Select.
We began our antibiotic stewardship program about 9 or 10 years ago. This was at a time when it became very well recognized in the medical community that we were using more antibiotics than we needed to, and this excessive antibiotic use was leading to a significant morbidity and mortality as well as increased costs. So we started looking at our own in-house antibiotic usage to see what we could do to rein in the use of antibiotics. I must say that when we started this, data drove what we were doing. This LTAC hospital in Nashville is one of 110 select LTACs in the country, so we have a large database with which to look. And we started comparing data from all our hospitals, how much antibiotic use was there at each hospital, and then ranking ourselves, which hospitals had most antibiotic use, which had least, and the ones that were more judicious in their use of antibiotics, we asked them, what are you doing to do a better job of using antibiotics than we're doing? We meet at this same room, this same conference table. There are 12 admitting physicians at this hospital, all pulmonary and critical care. And by getting together and discussing this issue, we were able to come up with several points that helped us decrease our antibiotic usage. Julie, you'd like to mention some of those pillars of our antibiotic stewardship program?
Sure. As David mentioned, this started a number of years ago, and I think the genesis of it was basically sitting around this table and discussing issues and what we needed to do to be better. Clearly there was more and more data emerging nationwide that antibiotic use was in most cases excessive, in many cases unnecessary, and looking at that data and then examining our own practices led us to make some changes. Obviously there's some national guidelines that helped us along the way, and those are what we started with as far as what we describe as our pillars of antibiotic stewardship. The first one was looking at length of antibiotic duration in selected patients, putting automatic stop dates on antibiotic usage was an easy fix to begin with once the physicians bought into it and understood why we were doing it and realized that that was very appropriate in most cases. The second one, which took a little more discussion amongst the physicians, was really looking at obtaining appropriate cultures and when to obtain cultures. Because the patients at Select had been at other facilities, often were colonized with bacteria from multiple sites, it really took a lot of understanding to interpret the cultures and say, maybe we don't need to treat this positive sputum culture in this patient that's been mechanically ventilated for the last 2 weeks. Let's look at the whole picture of the patient and decide whether this is appropriate or not. And I think that's a problem everywhere, and that's generalizable to many other facilities. Interpreting culture data alone outside of the whole clinical picture, it leads to erroneous prescribing. We have to look at whether the patient truly has an infection rather than just a positive culture that is interpreted then as colonization. We did a lot more cultures when we first started this project, often just culturing patients when they arrived here to see what they had, and those cultures led to prescribing that really didn't need to happen. And so it took meeting all of us together to say, maybe we should not do empiric culturing or surveillance culturing in those patients, and let's wait and see what happens with the patient. Or if we have a positive culture, let's go back and look at everything before we make a knee-jerk decision to prescribe antibiotics. And I think that's probably been what's led us to the great success that we've had so far.
I certainly agree that what we find physicians do is treat cultures instead of the patient. And patients who've been in the hospital for days or weeks at a time are always colonized with bacteria. So a sputum culture or a tracheal secretion culture in someone who's been in the hospital for days and weeks at a time really doesn't tell what the status of the patient is, because they're almost always positive. And if we just keep treating those cultures, we end up treating patients that do not need to be treated. Now, that took some understanding among all of us physicians, that we discussed that as a group, and we've done this now almost 10 years with great success. Just to throw out some additional data, of the 110 LTAC hospitals in Select, the Nashville LTAC has the highest case mix index. We just see the sickest patients by far, more ventilator patients, more hemodialysis patients. So our patients are not well, they're sick to begin with. But in spite of having the sickest patients in this large company, the 110 hospitals, we have the lowest antibiotic use, the lowest antibiotic costs, and because of that, the lowest pharmacy cost in the entire company. Now, that wouldn't work unless our patients did well. So we certainly look at how our patients do, and again, we have to compare ourselves to the other LTACs in this company and nationwide, and we have a much lower than expected mortality rate and a much higher than expected ventilator wean rate. A significant number of our patients actually recover and are able to go home as opposed to a different level of care. So I think we've shown over these 10 years that we can lower antibiotic use, have good outcomes, and lower the cost of health care. We truly injure people by overprescribing antibiotics. Dr. Horton has been our key person in this. Several years ago, we put together an antibiotic ID group, ID physicians from around the country, and came up with pillars of suggestions of what we could do to lower antibiotic use, not just here but throughout the company. And by taking those suggestions and emphasizing that effort, Select has been able to decrease their antibiotic use over these past 3 or 4 years by about 24%, which I think is very striking.
The other things that we instituted were IV to PO conversion, which again I think was a relatively easy institution as far as operationally. The pharmacy is able to do this and converts patients who are on IV medications to an oral equivalent when that's appropriate. And the final pillar that we have instituted, and this is still a work in progress, I mean we still examine our data all the time, but was having an automatic ID consultation for patients that are on an extended length of therapy of antibiotics, patients that are on more expensive antibiotic therapy, and patients that are on more than one or two antibiotic agents. So there's a list of medications if a patient is admitted to Select on those medications that I'll get a call about and review for the appropriateness of that data. And what I found is quite interesting. You know, patients come from many other facilities around the area, but I often find that it may actually be sort of a random number that's picked about how much longer that patient needs to be on these 3 or 4 or 5 antibiotics. And I don't think that there's any malintent on the part of the prescribing physician previously, but they just want to make sure the patient is going to do okay, and perhaps doesn't know that there's what supervision the patient will get or who's going to be treating the patient. But oftentimes the antibiotic therapy has really been adequate by the time they get here, and more in this case is not better. I think that's often our comfort level with antibiotics is so great that we think it's okay to prescribe another week or 2 of this medication because what's it going to hurt? Well, we know from a lot of experience that there's harm that comes to the patient, both by toxic reactions related to the antibiotic itself, Clostridium difficile, which is obviously a huge and growing problem, alteration in the patient's natural flora from being on the antibiotics for so long, and then harm that comes to the community at large that we all live in, that we have seen an explosion of antibiotic resistance, in part related to our overprescribing of antibiotics. We've seen just in the last few years a marked increase in extended spectrum beta lactamases, for which we have very limited therapy, and those now are community associated. We see those in patients coming in from the community who'd had very little antibiotics exposure previously, so we know they're circulating in the community. And recently we've also seen carbapenem resistant organisms. Fortunately, those are relatively rare now, but unless we change our prescribing habits and really rein in antibiotic use, those are going to become a major problem in many cases without any therapy to treat those.
Until we started this initiative 9 or 10 years ago, we used antibiotics excessively, just like everybody else did. When we looked at our data at all the hospitals in the Select LTAC system, we actually used more antibiotics than over half the other hospitals. Now, with the antibiotic stewardship program, we've had the lowest use of antibiotics year after year after year. We have changed. What we did 9 or 10 years ago and the way we treated patients is not what we do now. And what we were doing then was doing more harm than good, because we were over-treating people with antibiotics. But by getting physicians together, having educational symposiums led by Dr. Horton, we were able to educate ourselves that we were overusing antibiotics and there was a better way. Doctors always want to do the right thing. Never been a doctor that's written an order that didn't think he was doing something for his patient. Sometimes we just don't know, that we need to educate ourselves, and I think that's what we've done here with Dr. Horton's help. We've just talked among ourselves that we don't need to use antibiotics in all these cases. For example, just a hypothetical case, it's a typical patient we see. If a patient came into Vanderbilt or St. Thomas or Centennial with a septic shock, they ended up surviving and were hemodynamically stable, but they had ARDS on a ventilator. They may have had acute renal failure. We're going to require dialysis for another 3 or 4 weeks before their kidneys recovered. These patients live in the acute care hospital for 2 or 3 weeks before they come to us. They're trached, and those tracheal secretions almost always grow out some organism that's been colonized, that is a colonization from the acute care hospital. So what we found in a lot of hospitals, that those secretions will be repeatedly cultured, they'll be repeatedly positive. Maybe Klebsiella, maybe Acinetobacter, could be anything. And in the past, we would treat that culture just because it was positive. Physicians have a reflex. If they see a positive culture, by golly, that patient's going to get an antibiotic. But often that's exactly the wrong thing to do, because these patients are colonized with all these organisms, but they're not actively infected. They don't need therapy. So if we keep treating cultures and we never sterilize the sputum or tracheal secretions, then we keep people on antibiotics almost forever. And I think this understanding and realization among the admitting physicians that we don't have to treat cultures, we have to treat the patient and not just the cultures. What's worked well for us over these past 10 years is we've dramatically decreased the number of cultures that we obtain. We do not feel that patients admitted to an LTAC should be pan-cultured. We only obtain cultures when there's a clinical indication. That would be a temperature spike or deterioration of the patient's clinical status. But just obtaining cultures to obtain them leads to bad care. That's not only true with tracheal secretions, it's true with urine cultures as well. I think, as we all know, if a patient has a Foley catheter in for more than just a few days, certainly by 2 or 3 weeks, that culture is going to be positive for some organism. That's asymptomatic bacteriuria, does not need to be treated. If we treat that, then we get into the problems Dr. Horton alluded to, the toxicity, the C. diff, so forth. So it's a new way of thinking about cultures, a new way of thinking about patients. And we've been really pleasantly pleased that we have had a sustained 75 to 80% decrease in antibiotic use at this hospital over many years. We feel that's led to things like certainly lower costs, less toxicity, and lower C. diff infection rates. There is one new pillar of antibiotic stewardship that we are now discussing here that Dr. Horton presented to our group yesterday, and that would be the 3-day timeout and review of new antibiotic starts.
Looking at the appropriateness of antibiotics, a part of antibiotic stewardship is de-escalation. Oftentimes patients are quite critically ill, and in that moment you're worried about them, you don't know what's ultimately going to be the cause of their infection, and the appropriate thing is to treat broadly and to cover all the possibilities. So oftentimes patients, when they're deteriorating, are started on multiple antibiotics while cultures are being obtained, x-rays are being obtained, data is being gathered. The appropriate thing to do thereafter is review those cultures in the next day or 2 or 3 as they become available, and sort of target therapy at that point to what's appropriate. So they may not need vancomycin, for instance, if they didn't have MRSA. They might be able to be de-escalated to a lower level of antibiotic therapy. And so this has been termed a 3-day timeout. So looking at reviewing all the culture data after a patient's been started on antibiotics at day 2 or day 3, when that data is available, and saying, well, maybe I don't need to use meropenem, maybe I can use Ancef instead. Looking at whether they actually need the 2 or 3 antibiotics that they were started on. And in some cases they may not need any of those. It may have been a non-infectious cause of their deterioration. So we are in the process of instituting a formalized kind of 3-day timeout or review to look at that data in hopes that, again, we can cull out some of the ongoing inappropriate prescribing. Some of these later pillars become a little bit more difficult to institute. The automatic stop, the IV to PO conversion are relatively easy to do for institutions that haven't started those yet, but the 3-day timeouts, and it gets a little bit tougher. We've termed some of them low-hanging fruit that are easy to take care of. It gets tougher along the way, but clearly this is the right thing to do, and I think there is still progress to be made in that regard.
I think that's exactly right, and what we've also found that the pharmacist needs to take a bigger role in this arena. That in the past, the physician, and currently too, the physician certainly is in charge, the general taking care of the patient, but in the new medical era, one physician cannot know everything there is to know about everything. A lot of these drugs are very complicated now, they have lots of side effects. So the pharmacist should be very much involved with the antibiotic evaluation. It might be a drug interaction. The pharmacist, we've asked our pharmacists at the end of 72 hours to track down the culture data and be responsible for talking to Dr. Horton or one of us as the attending physician, just to say, here's where we are. And if that even decreases antibiotic use by 1 day or 2 days, that's an advantage to the patient. We feel that some of the newer antibiotics, the cubicins, Tigicil, should be reserved and used only in special occasions and only by ID doctors. We don't have many antibiotics in the pipeline. We're running out of tools to treat people with infection, and we need to preserve our best drugs for those patients who really need them and not just use them willy-nilly. That's why at this hospital we've made it automatic that our ID consultant, Dr. Horton, will see every patient for whom these drugs are prescribed. And if they come into this hospital from another hospital on these medications, Dr. Horton also gets involved with those cases to make sure that those drugs are indicated. How we as a group here use data to help decide best care. No physician or hospital knows how they're doing unless we look and see how we're doing and then compare ourselves to how everybody else is doing. Data is what drives medicine, And most doctors are data junkies. That's how we make decisions. We know that a drug works because studies have shown that it works. So it's helpful for each hospital to look at their antibiotic usage data and then compare it to other similar hospitals, like all LTACs, all acute cares. And if you see that your hospital is using this much antibiotic and somebody else is using this much and the average is here, then you have a problem. It's not that our patients are sicker or our patients are different, but there's a problem. Variability of use of antibiotics is a problem. Variability in medicine is a problem. If a lot of hospitals get good results using less resources and others use more resources and the outcomes are the same, we need to be more cost effective in how we handle this. In addition, I think what we've shown here is that lower antibiotic use has led to better patient outcomes than it did before we started this program. So we encourage all of our hospitals to show data to their medical staff, comparing what their antibiotic usage is compared to someone else. We also recommend that each physician be looked at. Here in Nashville, we tack antibiotic use to each physician, and then we show that in a bar graph at our monthly meetings. This is to let everybody know how they're doing. Again, no doctor's ever written an antibiotic that he didn't think was indicated, but sometimes we all, including myself, write an order for a drug or an antibiotic that maybe wasn't indicated. And it's only by looking at the data to see how we're doing compared to everybody else that we have a chance to make a change in our own prescribing behavior. Data drives everything in medicine.
So we instituted this program approximately 10 years ago and made great strides initially and continue to make strides, although at a bit slower pace given where we are now. I think it's the sustainability of this has been, one, because our medical staff has been fairly constant in that time. We've had some new physicians join us, but who've understood that the way that we operate here at Select. I think it's been educational for them. So they realize that, I'm sure that they take what we do here back to other hospitals where they practice and utilize that those practices there as well. I think it's it's still a work in progress, so we still monitor things. I mean, the pharmacy is heavily involved as far as length of antibiotics, or they're not afraid to pick up the phone and say, hey, do you know that so-and-so has been on, cefepime for the last 10 days? Are you, tell me why you're using this. Do we need to get Julie Horton to come see the patient? So I guess maybe it's the constant threat of my intervention. But I think in sitting around the table and looking at it, I think doctors, they've had a real buy-in to it and realize the outcomes are good. It's a lot of it is a comfort level. It's a little bit scary sometimes to say, you know what, you don't need to use 3 weeks of antibiotics for this problem. Really, the data show that 7 to 10 days are enough. We don't need to do this ongoing. And that might be a little, in some ways, scary for them to stop that. But once they see that they did that patient did well, they can incorporate that into their practice going forward. It can be difficult. It's a change. People, we don't like change. We like to do the same things we've always done. And in some ways, it's a little bit, there's a lot of uncertainty to it. It's very worthwhile. It's very rewarding once you see the results. And I think, what David emphasizes often is it's data-driven. Doctors they want to see what the data is. And I think if you put numbers in front of them, which again may be hard institutionally to collect. I mean, it's very difficult. It's easy to say to compare your antibiotic usage to other facilities, but that data is difficult to find out. Now I think with some collaboratives that are going on, we may be able to have that data may be more available where we can compare ourselves to others or compare ourselves to how we've been doing and see that we're making progress. But I think that's a key to making changes. I mean, you can say all these things and put them on a memo, but until you measure them and follow them, you don't know. You can't see the success that you're having.
I think it's important to emphasize the role of the infectious disease doctor. The ID doctor is looked at by the staff to make the right decisions regarding antibiotics. And so the ID doctors have to buy in to the realization that antibiotic stewardship is important and provides better care to the patient. We find a lot of variability in how ID doctors buy into that program. So it's very important that the ID doctors get on board with antibiotic stewardship, realize that treatment of colonization is rampant and needs to be reined in. But without the buy-in of the infectious disease doctor, it's unlikely that the program will work. Often that's about re-educating ourselves. As I mentioned, it was until 10 years ago where all the same doctors, we were using more antibiotics than we needed to, and we thought we were doing the right thing. 10 years ago is when we had our epiphany, so to speak, that maybe we could do a better job. And I think it's important for the infectious disease doctors to look at their hospital, look at themselves, and say, are we doing everything we can to rein in antibiotic use? And to look at data, as Julie mentioned, data drives everything. So every hospital needs to compare how they're doing with everybody else. And if your numbers don't look good, then usually you're doing something wrong, and that can be addressed.